I'm Sarah Halter. I'm the Executive Director of the museum. Very glad to welcome all of you here today, especially those of you who are members or donors, or I see at least one board member, Bill Schneider, stand up and bow. Thank you all for being here, and thank you for supporting the museum and our work here. We're really excited about all the things we have going on, so we're glad to have you along for the ride with us. Writer and historian Bill Beck, I'm going to read this one so I don't mess it up. Writer and historian Bill Beck has more than 30 years of experience writing about business and institutional history. He wrote his first history for Minnesota Power in 1985 and has more than 100 published books to his credit. In Central Indiana, he has written anniversary books for Park Tudor School, Indiana Gas Company, Riley Industries, Indianapolis Business Journal, Millennial Project, the Indianapolis 500 Festival, the IHSAA, and St. Vincent Hospital. Bill's a 1971 graduate of Marion University in Indianapolis, and he did his graduate work in American history at the University of North Dakota. He started Lakeside Writers Group in 1988, following 10 years as a reporter for newspapers in Minnesota and North Carolina, and 7 years as the senior writer in the Public Affairs Department at Minnesota Power. He lives in the Irvington neighborhood of Indianapolis with Elizabeth, his wife, for 55 years. He's been a member of the Marion County Historical Society for nearly a quarter century. Dr. Bill McNiece, the other Bill, I often refer to the Bill, and it's always Bill McNiece.
It works.
Dr. McNiece is a lifelong resident of Indianapolis with roots in Southern Indiana. He's a graduate of Rhodes-Holman Institute of Technology and Indiana University School of Medicine. He's a physician and practicing anesthesiologist. He serves as president of the Marion County Historical Society. Is that still true?
Yeah, so far. Let me know if you're interested in. Okay, fair enough.
His historical interests include anesthesia and anesthesiology history, local history, and industrial history. Please welcome Dr. Bill McNiece.
All right. Well, thanks to all. I'll first make a note just on behalf of Bill Beck. As he expressed it, I had a medical emergency. He is doing well, otherwise he would be here. We typically kind of bounce back and forth in terms of our presentations, but it's just going to be me today, so we'll work our way through this. But thanks so much for coming out, and we'll be able to see me okay on the screen.
Please hold.
A little help here, please.
You're there. I see your screen. I see your
Okay.
beautiful face.
Can you help me advance a slide?
Oh, it's, yeah. There it goes. It's not working.
No. Where's the bleep button here?
Maybe something else will work.
Whoa, stop.
Hey.
What did you do?
I did something.
Thank you.
It worked, so let's not ask questions. There you go.
Okay, I think we're here. And will that screen, oh, that one, I hope disappear pretty soon. Okay, well, let's go ahead and get going. So we were looking for a title for this, and so we opted for the White Plague in Central Indiana, continuing story, because that's kind of what we're talking about today. So the White Plague, not a real current descriptor, but commonly used in the right era. Just touch the 4 buttons.
Okay, we might have to just. I'll just stand here.
That'll be it. Whatever works. So when we're talking about the White Plague, there's a number of different names that we can attach to this. And as I talk today, I'll use several of them because it's consistent with the eras that I'm talking about. So phthisis is probably the longest, the oldest of the terms, dating back actually into the Greeks. The king's evil has to do with kind of infection involving the neck. And at the period of time, if the king, or I guess in that case also a queen, would come by and touch this area, the idea was that would heal that. Well, it seemed to me it would be more like to spread that rather than heal that, but that's the way that it was. Captain of all these men of death, pointing out that in one period of time, there was just profound death resulting from tuberculosis with that descriptor. The robber of youth, because you can, if you look at the breakdown of deaths due to tuberculosis, you'll see kind of a rise in the area of the 20 to 35 age range. So that came the robber of youth. Consumption, and we'll talk more about that because it tends to consume the musculature, and the people's the individual who has it tends to become fairly depleted of stores. And then tuberculosis and certainly TB. So these are all different names for the same thing. You'll hear me use them a little bit more here and there. So what are we talking about? Mycobacterium tuberculosis, the organism that's involved here. Pulmonary tuberculosis is really probably the most common form of it, but we can see tuberculosis in other locations in the body. So when I talked about the king's touch and solving the problem of scrofula, that's TB involvement of the cervical lymph nodes. Come on in. It's good. Pott's disease, tuberculosis of the spine. We'll talk a little bit more about that. And then you can certainly have tuberculosis in other areas of the body. But we think of tuberculosis, we think mainly of the lungs, but in fact, it can be around in a number of different locations. Well, this is the introductory paragraph on a paper that I ran across, History of Tuberculosis, Early Records to the Isolation of Koch's bacillus. TB is a contagious infectious disease due to Mycobacterium tuberculosis, which usually lasts through the life course and determines the formation of tubercles in different parts of the body. It has very ancient origins. It survived over 70,000 years and maybe much more than that. Currently infects nearly 2 billion people worldwide. There's about 10 million new cases of TB each year. Almost 1/3 of the world's populations are carriers and are then at risk for developing active disease. It's always been associated with a high mortality rate over the centuries, and now it's been estimated to be responsible for 1.4 million TB deaths on an annual basis. So this was just intended as a paragraph, but it does give you a pretty decent sense of what we're talking about with this illness. Well, from there, let's back up a little ways. And we can talk about where we have seen evidence of it in the past. So the Egyptian mummies from 2400 BCE do have spine deformities that are very characteristic of TB infections, Pott's disease. There are written descriptions from India and from China that give good evidence of this. Hippocrates describes it in Greece. There are descriptions in the Roman Empire, Byzantium, and the Arabic Empire. It's been identified in pre-Columbian mummies in South America, so evidence that tuberculosis is present prior to the time of Columbus. There is, dating back as far as 1679, descriptions of tubercles. This is a little weird. Well, we'll work with it. So this is an article from 1720. It's kind of a small book. A new theory of consumption, phthisis, consumption of the lungs. And this physician in England talks about what he will be talking about and over the course of this writing. Any idea? Okay, we don't know. So I don't know which is easier to read, but talking about of consumption, consumption of the lungs is the most deplorable and what we most frequently meet with, our English people being in a very particular something to it. I design chiefly, but would lightly touch on other aspects, excepting insofar as it relates to the cure. Well, this is not exactly what I'm expecting here, but we'll work with it. So as a general rule, so what he's talking about with the consumption that it's making strong men weak to fall into distemper, have a much weaker and difficulties related to that. And so here in this section, there's some stuff that's worth reading here, but what he's describing underneath this is a very good description of what we would think of as acute tuberculosis today. So we're talking about things such as problems breathing, lots of coughing up lots of stuff. We talk with that about over a period of time, characteristic loss of weight and of muscle mass. So he has really a fairly good description here of what goes on in acute tuberculosis from his description from 1720. And I don't know if it's quite here or not. Maybe the next one, no. So what would be nice to demonstrate here is that he used language that he talks about the presence of little animalcules, as he described it. So the small beasties that he suggests could be the underlying common factor for these presentations of tuberculosis. And he says, you know, there's different phases to it, but if we could just figure out how to deal with those animalcules and take care of them, then that would really solve the problem with this disease. Now, there might be lingering after effects. You know, you get a scar from banging your knee or something. But this is an early description, 1720, of how he is suggesting this disease has its origins and moves from individual to individual. So that's 1820, 1720. This is Cook, 1882. Sort of an interesting person, accomplishes a lot, also has some efforts that didn't go very well. But he has announced that he has identified the cause of tuberculosis and then published his work 3 weeks later. It's in German, I haven't read it, but I'm going with it. So what he says that he has observed the bacillus, because these look like little rods, in all cases of the disease. He has grown the organism outside of the host, and then he has reproduced the disease in a susceptible host using a pure culture of the bacillus. So he is using this as demonstration that this bacillus is really what's behind all of this. And so here is an image, and you can see that within this image, there are these little straightish, bendy red things. And these are the acid-fast bacilli of Mycobacterium tuberculosis. So this is a modern image, but this would be what he would be describing and what he saw in his preparations that he is advancing. Well, from there, let's look at this. William Osler, name may ring a bell to some of us. So well-recognized physician. This is from the first edition of Principles and Practice of Medicine. So his textbook of medicine, first edition, 1892. And if you look at that, he starts out section 1, multiple sections in the textbook, specific infectious diseases. And you can see that there's a number of them listed here. Smallpox and measles and influenza, yellow fever, a variety of other things. But most of these kind of get 2 to maybe 7 pages, something like that. And then we go to the next page, and we can see here at the top, this is the tuberculosis part. It's 70 odd pages. So in this period of time, 1892, when he writes this first edition, there is awareness that there are many manifestations to tuberculosis. And he goes on from there to talk about a variety of aspects of it. And we'll look at a little bit here. So he says here, what it does say, what I'm expecting to say here is a description of the way that it presents and in different areas and how it shows up and appears. He talks about treatment of tuberculosis, and these can be a little off the wall today. But he points out that it's not unusual to have spontaneous healing of local tuberculosis. In effect, it kind of walls off, it settles down, and then the individual can proceed on and about their way. It can also become major problems, but there are times that it will become kind of sort of a latent phase, and the individual will go on about their lives. He also talks then, okay, well, I kind of know what's going on. So what this section would go on to talk about is that in his view, the best approach to dealing with tuberculosis is to provide good nutrition, to provide plenty of fresh air, and to then allow this individual to, in effect, get through the illness through this optimality of nutrition and fresh air. This is an article you'll see at the bottom, J.N. Hertie, Hertie Hall, if any of you have been to the Indiana University School of Medicine, former dean's office area, and where I had an office at one time. J.N. Hertie was for a long time professor of hygiene. At this period of time, he was the secretary of the Indiana State Medical Association. And so what he is talking about in this article in the Indianapolis News, he talks about sanatoria for consumption. So he is following along in line with what Osler was saying, that really what you need is open air. So open air life cures consumption, and they're more than probable that ventilation is really important. He talks about a state sanatorium for indigent individuals really should be constructed. And in fact, if you just construct it and these individuals would be there, then in fact, they would get better. And in the long run, you, state government, representative centers are going to save money by constructing sanatoria for the care and healing of these individuals. And he talks about this, and he then proceeds to say, well, we're a little bit behind the times here in Indiana. You've got it in various other states. This is something that we really should be doing in the state of Indiana. It actually happens. Takes a while, takes about 5 years, but it really happens. And so this is the first and second parts of an article that talks about there is a bill passed to provide for a tuberculosis hospital. So this is in 1907. The state legislature passes this, and then you can move forward to try and find the location and construction for this Indiana tuberculosis hospital. This is another textbook from about the same period of time, so 1909, Tuberculosis, a Preventable Disease and Preventable and Curable Disease. This individual, German by extraction, writes on a number of different articles. And in this text, he talks about tuberculosis and what can be done about it. And he divides this up into different chapters. And this is a list of his chapters, and he describes it as duties. So first chapter, duties of the people. What should we expect of people? To go out and be aware of the problems of tuberculosis, know what to look for, know how to react in the event you're in a situation where tuberculosis is going to become an issue. He goes on down to talk about duties of physicians, of sanatoriums. So this would be the location where an individual would go for a period of time if they either get tuberculosis or in a position where they kind of are at risk for it. So this would be an area where they could get good nutrition, where they could have a good environment, good airflow around them. And hopefully over a period of time, they're going to learn better how to address these things and can then move forward to avoid further problems with this. He talks about health authorities, probably a good discussion here, state and federal authorities. He talks about employers and what employers should do in terms of the hygiene of the workplace to try and minimize the likelihood of transmitting the tuberculosis one to another. School teachers, how they should deal with the environment of the classroom, the press, and the clergy. And he, throughout all this, really promotes the idea of sanitarium. He says if you can get good nutrition, if you can get an appropriate amount of rest as needed, and lots of fresh air, then these are very good things. He goes on to make some suggestions on where this might happen, but really says, the really important thing is lots of fresh air and good nutrition. And so this is the building that eventually gets constructed. This is the State Tuberculosis Hospital in Rockville, Indiana. There are later photos, but this is a photo from probably the year that it opened, so probably around 1908, 1910. Rockville, Indiana is in Park County. If you've ever been to the Covered Bridge Festival, that's about where it is. And so this then becomes the State Tuberculosis Hospital for Indiana. It is described as having kind of the best of everything that you would want for the care of the individual with tuberculosis. It's at the time the one on the state. It really provides care to everyone across the state. That becomes very quickly a problem because there's just not enough room in the end there. But that's where it is. And it becomes apparent fairly quickly that, well, we really need more of these. And so then there develops a movement to have others around the state, often on a county level, to deal with this. This is an article by Dr. Geckler treatment of pulmonary tuberculosis with artificial pneumothorax. So this is an article written in October 1912. Dr. Geckler is in Rockville. The tuberculosis hospital is in Rockville. Pretty confident Dr. Geckler worked at this place. And he goes on and talks about this and talks about his experience with it. So artificial pneumothorax. See, he describes Murphy's method to do this. And the basic notion is you've got an area of tuberculosis within the lung. And if you add gas around that and collapse the lung down, then that gives the opportunity for some healing of that lung. And hopefully then the tuberculosis area will become quiescent. So he talks about doing this. This is done with local anesthesia. So making a small incision, dissect down, and then, and this is important, you use a blunt tip catheter. So you kind of pop through the pleura. You don't slide through the pleura because then you're more apt to snag things that's on the other side, such as the lung. And then he injects, as he describes, 500 to 600 milliliters of nitrogen and then closes the wound. It's not a very big wound by his description. So what you're left with then is on whichever side he is talking about, an area of gas that is within the chest between the lung and the outside. And it stays there for a while. So that's step one. From there, 2 or 3 days later, and with the use of X-ray guidance to be sure that you're not sticking the lung, but you're putting your needle into this pocket of gas, then you add a little more gas to it. And you do this weekly for a while, and then every 2 or 3 weeks for a while. And over a period of time, then that should result in collapsing down and healing of the lung. That's the idea behind this. Now, importantly, this only applies to unilateral pulmonary tuberculosis. If you got it on both sides, you can't do it on both sides at the same time. So that just doesn't work. And he says that the success then depends on how much of the lung can be collapsed. One of the problems with this is that if you get the lung that is scarred to the inside of the chest, then it can't collapse down. And so this idea of collapsing the lung to giving it an area to heal just doesn't work very well. But he proceeds to use this. If there is good collapse, then the cough rapidly diminishes. Recall that with tuberculosis, tremendous amount of coughing, lots of production of sputum. And so if this is successful, then that amount of sputum decreases markedly. The fever declines, the patient is much more comfortable, they feel much better. Their nutrition then can improve, the patient regains weight, and all in all, they're markedly better because of this. He suggests the mechanism that the improvement relates to reduced drainage of toxins from the diseased portion of the lung. I'm not sure, but maybe. And in time, then the affected area of the lung scars down and contains the tuberculosis, and the patient will do better. So he talks about what he has done here. He reports on, as I recall, 11 cases. And I can't remember my exact numbers here, but I think in 3 of them there, it just didn't work terribly well because it couldn't collapse down. 5 of them, it worked reasonably well. 2 of them, there was something else. And then there was 1 that he thought was really great. And I can't show it to you, but that's okay. But he points out in this 1 patient who was an 18-year-old and then really kind of extremist. He was tremendous coughing, tremendous fevers, wasting. It was clear that the handwriting was on the wall of they didn't try something. So they tried this, and with pretty good success on this individual that he writes about. So here we're talking about some success in this description of what's going on here in Indiana over in Rockville as a mode of therapy for tuberculosis. Let me show you a couple of pictures here. So this would be an example where you've got kind of disease everywhere. This is a fairly recent example of miliary tuberculosis. So this is really little bits of diseased tissue all throughout the lung. So that's not really what they would be talking about here. Now, this would be an example where you've got some scarring of the lung here. You've got some infection going on here. This is an area up here where there is, if you will, a hole. And so that is an area where you would expect tuberculosis to be, and an area of big problem if that's not able to be collapsed down. Not sure it would be applicable, but that would be an example. Now, let me show you, I think, yeah, here is 2 slides. These are two different individuals. These individuals, I can't remember the exact details, but they're both in their 80s. They were seen in a hospital setting. And we got these 2 x-rays of 2 different individuals. What's going on? It's tuberculosis related. So we talked about a method of treating tuberculosis with the pneumothorax of collapsing the lung down. These are 2 other methods that were used to do that. So in this one, you'll see these kind of round ball-like things. And that's exactly what they are. They're round balls. And they were inserted to collapse down the lung in this individual with tuberculosis. This is an injection of some sort of described as oil of paraffin. Not sure what that means, but that's what it's described as. And again, to provide collapsing down. So these are treatments that these individuals received in probably when they were in their 20s, maybe 30s, and now they're in their 80s. So these are 2 examples of other approaches to this kind of mechanical treatment of pulmonary tuberculosis. Okay, let's talk a little bit more. Here is some public health figures. 1914, so we've got the hospital going. We've got 473 deaths from tuberculosis in Indianapolis in 1913. A previous high was 420. Didn't have any problems with smallpox that year, but clearly this was an issue because we're seeing more and more deaths related to tuberculosis. And for that, let me just digress for a moment. Where I am here. So there are all sorts of things that we can talk about in terms of how tuberculosis affects people. This is a couple of maps here. So the map of Indiana, probably all know that. The county there is Jackson County. And if you move from Jackson County to here, this is Hamilton Township in Jackson County. I think you mentioned I have Jackson County origins, so that may be part of the story here. So this is a portion of the census from 1900. And you can see here, there's the Samuel Brock family. And Samuel and Elisa has 6 children. They will go on to have another younger son in a year or 2. But this is their family, and you can see that they've got Lucy, who is a 6-year-old girl, and her younger sister, Nellie, who is roughly 2 years younger. And so Lucy and Nellie then become an important part of the story. Lucy, mainly because she is my grandmother, who I never met, and Nellie because we're going to go on to talk a little bit more about Nellie. So this is the 1900 census. If we would go to the 1910 census, we would learn that Gertrude, the oldest of the sisters, has married, has moved out. She's got a young son. And Nellie has moved into that household, I guess, as a mother's helper sort of thing. So she's there for a period of time. And then we can read later on that she moves back in with her parents. So this is 1900. We've talked about 1910. And then here is an article from the local paper from 1916. Miss Nellie Brock, 20 years old, died at the home of her parents about 4 o'clock of lung trouble. Been sick for a little over 2 years, really never confined to her bed, and was sitting in a chair at the time of her death. Talks about the funeral service, talks about her survivors there, including Mrs. Lucy Forgey, who is my mother's mother. So, lung trouble. But if we keep going a little bit more and we look for her certificate of death. So it looks kind of like Kelly, but it's really Nellie, and kind of ignore the spelling of it. But you can see here that the cause of death is pulmonary tuberculosis with general weakness and exhaustion by the physician who signs this as the cause of death. So this would be an example of how in a small town out on a farm, remember her father is a laborer, is a farm laborer, then this family, not in the big city, not working in a big factory, but how this affected people kind of anywhere in the state or anywhere else. Interestingly, she's the only one I can find any cause of death or any suggestion that they had tuberculosis. I bet others probably did, and then it kind of entered a latent phase. But her siblings all lived into their 50s or above, and her parents did as well beyond that. So she was kind of the isolated case. But here you are. We talked about how it can affect the youth. There's a young woman, 20 years old, who dies of tuberculosis. But I digress, so let me move on from there. Let me move on. We talked about a little bit about the sanatoria and how good nutrition, teaching about good health, lots of open air. So there's another movement called the open air school movement. And so this was an approach to provide plenty of fresh air to students. Teach academics, provide for exercise, be sure they get rest, be sure they get good nutrition. And the first one here in Indianapolis is the Lucretia Mott School. At school number 3, opens in 1908, but then gets transitioned into the first open air, sometimes called fresh air school in Indianapolis. It's over on Rural Street, just north of Washington. Here's an example of the outside of the school up here on the left, and that's what I'm seeing there. And if you have a look at the students, you'll notice a few things. In their classroom, first off, the windows are open in their classroom. And you'll see that these students have barely heavy clothing on in the middle of their classroom. So these were called their Eskimo suits. And then the idea of this was that they would wear these sometimes over their clothing to keep them warm while still having plenty of fresh air coming into the room as part of this fresh air, open air movement in education. Let's move on to look at, I think, in a fairly important article here. This is a pamphlet that is produced and developed from 1927 to 28. The Hospitals of Indianapolis. It's an interesting read broadly, but it also enlightens us some about tuberculosis. So the U.S. Census Bureau estimates the population of Marion County about 275,000. Might be a little bit bigger in time. about 45,000 of these. And I will use, I hope gently, the word that appears there, colored, to refer to individuals, African Americans at the time, because that's the language that was used here. So if we look prevalence of notifiable diseases, these tend to be diseases that can be transmitted. And you'll look down here on our list, and we can see that we've got looking at tuberculosis, deaths registered, and it's a pretty significant number here as you compare to all the others there. Pneumonia in all forms. Now remember, some of those forms might have been tuberculosis. So in fact, the way this is distributed might not be exactly right. Looking at the vital signs over this period of time, death rates, you can see what we have here. Mortality tends to be higher in the colored population, as you compare here, and that's a characteristic that we'll see in other areas. Deaths by principal causes over this period of time from 23 to 27, same sort of information that you're getting here, that the cause of death of tuberculosis is pretty important. We'll move on to look at one of the hospitals, and that's Sunnyside, which is the Marion County Tuberculosis Sanatorium. It's up on the far northeast corner of the county. Talks about the way this hospital operates. This is an example of it. I can't remember the exact date on this, but in the 20s. And so this gives you an impression of what the hospital looks like. You can see the main building. So it has some open areas, some open porches. There's a lot of areas around here to allow lots of fresh air around the patients here. This is a classroom setting because children were admitted to this hospital for a period of time. They might be admitted there for at least months and sometimes a year or better. So these are students that are in this classroom. We have James Whitcomb Riley kind of looking over all of them here. They've kind of all got long sleeve and sweaters on. The windows are open that you can see here. So they're following this idea of open air and plenty of fresh air. Talking about the admissions there for the last 3 years, the hope was that you could take people who were very early in this process and then not have problems. You could teach them, you could arrest it, you could get them good nutrition, they would do better. And there was then, if you had these far advanced patients, maybe this was just not the optimal place for them. Admissions over the several years there, you can see that there's a number of pediatric patients in the 5 to 15 years. Duration of treatment, sometimes less than 30 days, but regularly, months in terms of duration. One of the discussions was, well, probably you're gonna do as much as you can in a year. And so should you really be keeping any patient beyond a year? Because if you're doing that, then you need more space for them. We can see that deaths, a little bit of a trend downward maybe over this period of time, but talking about the various pneumonia deaths too. So that is a considerable portion of these deaths, maybe as high as 25% due to tuberculosis. The Women's Improvement Club is an important organization. This is a group of about 20 women, well-educated women, colored African-American people. They've got some personal interest in tuberculosis. So this is a major effort of this benevolent organization. And this is one of the examples of one of the areas that they did, the convalescent camp at Oak Hill, 1905. And these are women and children in this very open area. as an effort, therapeutic effort to improve their health in light of tuberculosis. Might be better to be able to talk about clinical and non-clinical. So if you had children who weren't doing too bad, maybe you should try to keep them separately. And so this is what they say, they belong in a preventorium as opposed to a sanatorium to try and provide better care for these individuals. Effective group of women. Talking about this and the connections with the city hospital, later on the county, later on Wishart Hospital, and now Eskenazi. Talk a little bit about other initiatives. These are Christmas seals. Emily Bissell is the crusader against this. These are early stamps. I think this is 1907, 9, and 11 that you're seeing here. These were methods where you could not too painfully make contributions against tuberculosis. Talking about these, here's an example of Red Cross seals from 1910. This is an article from the Richmond newspaper. This is certainly a question, not just in central Indiana, but broadly around the state and beyond. There was, interestingly, an article immediately above this that isn't there, but it talks about some patent medicine remedies for it. Here is an article, and you can see these are all talking about the value of Christmas seals and various promotions of it. This is a big article in the Indianapolis News. Again, more about Christmas seals, promoting them as a development source for providing money together in support of treatment of and research on tuberculosis. Eli Lilly heads the drive here in 1940. Also in 1940, this is a new state hospital. So this is in Lawrenceburg, Southeast Indiana. New 150 bed Southern Indiana Tuberculosis Hospital opens today. There's just not enough room for the individuals who need treatment for tuberculosis. Now, 1944, streptomycin appears. This is the first anti-tuberculosis drug. It has some effectiveness. Development resistance is fairly common. Significant problems in terms of vestibular dysfunction, but still it's the first thing that we've got that has some value to this. If we look at some landmarks over a period of time, we can see that over the period from 1944 into the 1980s, there's a range of different drugs that become available. And you can see in 1952, there's already a discussion of triple therapy, so more than one anti-tuberculosis drug, and for a period of time, here 24 months, that becomes a big issue in the treatment of tuberculosis because you're requiring a long, extended period of treatment for success. And you can see from this slide, tuberculosis therapy, it kind of needs, in this one, 5 to 6 months to have a fair amount of cure with whatever approach they were using here. So we are talking an extended period of time. And importantly, the therapy has to be taken every day as needed so that this is a continuous therapeutic period of time. And it's not up and down in terms of your blood levels of the medicines that the patient's receiving. But these anti-tuberculosis drugs gradually get better in terms of their efficacy, the need for sanatoria decreases, and so these sanatoria gradually close in the 1960s. In fact, by the 1940s, the open air school movement had faded away too. So this is a current look. This is called the sanatorium. This is part of the the Indiana Tuberculosis Hospital. It's not in great repair. It's being promoted now as a place for amateur, I think the name of this one, investigators of the paranormal. So you can go there and you can spend the night in this environment. You can pay money to do that. Just so you know. This is on the left. This is part of Sunnyside. You can judge from the cars here. This is an overview of what this is now. This is Northminster. And I'm pretty sure, where are we here? I think this is kind of this original part and everything else is built around them. So this is a continuing care community on the northeast side, Westminster Village North. And then this is the school that we talked about, the open air school, school number 3. It's now gone through 2 or 3 iterations, but it's now into apartments on Rural Street, just north of Washington. Where we are today, we know that there's a lot of tuberculosis in a lot of different places. We're going to talk a little bit more about this in the next about 4 minutes here, and then we'll go on from there. So if we look at this global TB statistics, 2 billion people harbor a dormant form of Mycobacterium tuberculosis. And over a period of time, that may reactivate for 5 or 10% of them. And these are the evidences that you might see of tuberculosis moving from a latent or dormant phase into an active phase. This is an example of the various drugs that have been developed and are in development for the treatment of tuberculosis. And then you'll see this kind of blue mountain that's coming up here. And this talks about the development of resistance. And so this is becoming a big problem because you've got resistant tuberculosis. You've got tuberculosis varieties that are resistant to multiple ones of the drugs. And then you've got extreme examples. And so these are big problems. And especially when you've got a limited number of medicines that are available. And we've got a lot of questions on what might be developing here to improve the situation looking into the future. This is an example about a little cartoon about how these different medicines might work in different locations. So there's a lot of different areas that they might have some efficacy, and that may make the therapeutic decision on which ones you might select. So where are we today? This was the slide that I just showed you. We know there's a lot of tuberculosis out there. It's a major public health concern. The development of resistance to medicines is a big issue. The duration and complexity of the therapeutic protocols, and then we certainly need to develop new medicines and new protocols. I will show you this one briefly. So this is an example of how you can see a tuberculosis outbreak. This is an example from Marion County from 2009. This one looking at this is the one I wanted to look at here. So gradually, we have seen over a period of time that there is a gradual decline in number of TB cases until we get up out here to 2020, 21, and 2022, and we're seeing some increases that are occurring there. Here's another one. If we look at this, from going up here to 2020, tuberculosis death in HIV positive people, deaths from HIV/AIDS, and now we're seeing that deaths from tuberculosis in HIV negative people are increasing, and now you're seeing more deaths from tuberculosis than you are from HIV/AIDS. I'll remind you that this is not a linear, but rather it's a logarithmic scale. So it looks worse than it does at first glance. A little bit in Indiana, just in the last years. This is kind of our trend here. We're a little bit up and down in Indiana from over the last 10 years. Number of cases, incidents per 100,000. So we're bouncing around a little bit here. Most commonly reported risk factors in TB cases in Indiana. You can scan down here and see the various things, including diabetes mellitus. The bone graft has to do with an episode where that was a problem, and then a variety of other factors here. Where are they? The darker is where we're seeing them, certainly in Marion County. Not surprising, we've got a bigger population here, but you can see it over a 10-year period of time. You're probably going to see it in most counties in the state. TB cases by county of birth in Indiana, and you will see some of them are in the United States. That's, I have to get my colors correct here. I think that's this one. But you'll certainly see that there's individuals coming from a variety of different locations. Where we're in age groups, again, a range here. And most of them are between 16 and 64. And talking a little bit about drug resistance. And you can see over a period of time here, going from 21 to 22, there's a significant increase in resistance to various anti-tuberculosis drugs. This slide looks broadly about how things have been, and over the period of time from 1860 to 2020, we've certainly improved things greatly over where we were over that period of time through a variety of therapies that are out there, but it's also clear that we've got a fair amount of work yet to do. I think I'll close with that, and however you'd like to proceed from here.